Hello, good afternoon. Welcome to the first ever BiteMedicine webinar. My name is Azim, and it's great to see so many of you here today. We set up this webinar with the expectation of about 50 to 70 people signing up, and over the last 3 days, we have had over 1,200 people sign up, which is absolutely fantastic. Given coronavirus and the fact that so many of us are self-isolating, we thought this would be a fantastic opportunity for us to give you some teaching from the comfort of your own homes. So a little bit about me. I'm a junior doctor based in London. I'm a recent surgical academic foundation program trainee at Guy's and St Thomas's Hospital. We set up BiteMedicine about 1.5 years ago to try and improve the medical education resources available to students all across the UK and further afield. So feel free to check out our website. We've got our new platform releasing in a couple of weeks with loads more very interactive and unique medical education resources coming very soon. So let's dive straight in. Our first topic is going to be on cardiovascular, and we're going to be covering 2 main conditions. So let's jump into our learning objectives. The 2 main cardiovascular topics. The aim of this teaching is that this is going to be super interactive. I want to see you guys messaging in the comments, and you're very welcome. Thank you so much for all of your kind words. And it's great that, I want to try and build a community here. And get you guys chatting with each other and asking me questions as we go along as well. We're going to be going through a few case-based discussions to identify our top differentials and why these are our top differentials, as well as theory to cover things like pathophysiology, diagnostic criteria, investigations, and management. What we also want to do is try and make this as interactive as possible. We've introduced Poll Everywhere, which is an interactive questioning system. So have your mobile phones at the ready. This is our first webinar, so we're hoping there won't be any technical issues, but we'll wait and see. And we're also going to be introducing our new multi-step single best answer questioning approach, which is a unique approach that's going to be coming to our platform as well that we want to introduce you guys to, because all the recent evidence and from our own experience being in your position recently, we believe that this is the best way to learn at medical school as we prepare for clinical practice. So let's dive right in. So let's have a look at our first case. So we have a 59-year-old chap who's presented to A&E with a 4-hour history, central chest pain with shortness of breath. Pain's constant, doesn't radiate, doesn't move, and he appears sweaty. So based on that, guys, what kind of things are popping in our head at this point in time? I'm seeing ACS, aortic dissection, be an MI, yeah, all of those totally reasonable. Good. Let's have a look. There he is, sweating away up here with his central chest pain. He has hypertension, rheumatoid arthritis. So is amlodipine? What's amlodipine? Simple question to start off with. Absolute calcium channel blocker. And methotrexate? Yeah, DMARD, a disease-modifying anti-rheumatic drug as an antifolate, folate antagonist. So he's on those 2 drugs, and he has some cardiovascular risk factors, as you guys seem to be saying as well. So well spotted. And he's an ex-smoker as well. So at this point, a lot of you guys are saying, cardiovascular sounding causes of this chest pain. Anything else? Yes, brilliant. I love that comment there. Someone's written, separating it by organ system, and I think that's something that I really would recommend. So we've thought about the heart. Could this be something cardiovascular? The lungs, absolutely. Could this be something like a pneumothorax, pulmonary embolism? So these should all be on our list of differentials as we narrow down which route we want to go down as well. And then as you guys are saying as well, is this GORD? Absolutely. It's less likely, but is this something to do with the gastroenterological system? So particularly for your clinical exams, if you can split it up like that, you'll do really well. Now, let's have a look at our observations. Anything at all spring out to you guys here? Heart rate of 72, 100/92, low BP, respirate high. Yeah, I'd agree with that. Other than those 2 things, I'd say he's a little bit hypertensive and he's a little bit tachypnic as well. So a little bit non-specific, nothing I would correct immediately over here. So that's the history. Now, let's have a look at his ECG. So I don't want you guys to say anything in the comments, if that's all right. We're going to work through this ECG systematically afterwards, but have a look at this. Hopefully you guys can all see this okay. And just in your head, have a think about what Are there any main abnormalities that you can tell? But don't write it in the comments if that's okay. We'll give you a few moments to have a look at that. And then we're actually going to do a session on ECGs in the future as well, but we will work through this next. So have a look. Is there anything there that springs out at all? Okay, so hopefully you guys had a good look at that. If there are any glaring abnormalities, I hope you've picked up on those. Now, here's the very technological part, which I hope works. So if you guys, let me send you this link, but it's also here as well. At the bottom of the screen, you can see a link, polev.com/app. You guys could visit that. That would be brilliant. And hopefully that should work, I hope. Can you post a link in the chat? Yeah, just give me a moment. Just want to make sure this is working okay for you guys. Okay. Sorry, it's the first time we've used this system. Hopefully that. Let's have a look at what you guys are saying. Okay, that's brilliant. Yeah, so if I take this comment here, I'll post it again. So yeah, if you can use that link, that would be great. No need to download. I've popped the link there, polev.com/BiteMedicine240. There's issues with that. We may need to skip it, but hopefully we can figure it out. Okay, so I think we'll have to fix that for next time, which is unfortunate. Okay. Okay, we'll fix that for next time round. I'm not sure. Let me see what you guys are saying. Okay, yeah, so that's not working. Let's have a vote on here. So we'll fix this for next time. So let's have a think. What is our most likely differential here? So we're saying inferior MI, anything else? Good. Oh, brilliant. Okay, so yeah, the vast majority of you are saying inferior MI. So let's have a look back over at the ECG. So what are our main ECG changes here that's indicating an inferior MI? ST elevation. Yes, exactly. Spot on, brilliant. So we're easing you guys in. So lead 2, 3, AVF, ST elevation is characteristic of an inferior myocardial infarction. And what is the most common artery that's going to be affected in an inferior? Good. Right coronary, fantastic. Straightforward. So 2, 3 AVF, right coronary artery indicates ischemia infarction of your inferior aspect of the heart. You can remember that AVF, F is for floor. We also have some reciprocal changes. So other changes that can be seen as well. So we've got some ST depression in V2, V3, and in V4 as well. So it's always good to keep an eye out for those as well. All of that make sense? Good. So a really, really common exam question that comes up. You guys can feel free to take a picture of this if that helps. Like we've just talked about, 2, 3 AVF is your inferior. So we've got right coronary artery inferior. So as I said, F for floor. We have lateral, so 1, AVL, V5, and V6. I like to remember this. L is for lateral as well, so that can help you remember it. And your left circumflex supplies that region. And then finally, we have your anterior or anteroseptal MI, so V1 to V4. If you remember those things, hopefully you'll be able to answer most questions related to ACS when it comes to ECGs. Now, slightly tricky question, posterior MI, what might we see on an ECG? Any ideas? Brilliant. Okay, so yeah, most of you seem to be mentioning reciprocal changes, ST depression, anterior lead depression. Perfect, well done. So yeah, what we would expect is ST depression in those precordial anterior leads. So V1 to V4, we're going to see reciprocal ST depression. In reality, what you may do is you may actually pop ECG leads like V7, V8 and attach them posteriorly, but that's very unlikely that's actually done in clinical practice. Can you explain why? Yeah, sure. If we think about the axis of the heart, if we're thinking anteriorly, we're going to see an inflection upwards, because when there's ischemia and infarction happening anteriorly, it just causes a positive change within the ST segment. When you're thinking posteriorly, actually what you're thinking is that everything's going to be flipped reverse because it's at the posterior aspect of the heart. So instead of things going up, because it's posterior, things end up going down. So it's essentially what you'd expect anteriorly, but posteriorly instead. So that's why you see those reciprocal changes with a posterior myocardial infarction. And just quick visualization of it. So like we were saying, right coronary arteries, your inferior MI comes down here. Do you know what artery pops off the right coronary artery in 80% of patients or people? PDA, perfect. The posterior descending artery. So this is the one that's most commonly occluded in a posterior myocardial infarction. We have left circumflex, which is your inferior MI, and then finally your LAD, your left anterior descending, is going to be your anterior MI. All that make sense? Good. I'm going to assume so. Fantastic. Let's have a think about the pathophysiology very briefly. So as we all know, ACS, which encompasses unstable angina, NSTEMIs and STEMIs, occur due to accumulation of low-density lipoproteins. So your nasty lipoproteins, you get coronary artery disease, you get atherosclerosis, which is not good. You then form these plaques, you then have leukocytes adhering to the sites of those plaques, and you get a thrombus being formed, essentially. So it grows and grows, you get platelets aggregating around those regions, and then that can potentially occlude your coronary arteries. When that occlusion occurs, if it's partial, you get ischemia, and then if it's complete, it can potentially result in an actual infarction, so myocyte cell death. As I said, ST elevation myocardial infarction is complete occlusion, and non-ST elevation or unstable angina is partial occlusion of normally one of your major coronary arteries that we just mentioned. So here we go. Hopefully all of us, nice, young, healthy, fit people with nice, clean coronary arteries popping up here. And I mean, other than myself, I'm in self-isolation. I'm eating a lot of rubbish these days, so maybe more towards here. But on the whole, hopefully we look like this. But then obviously we get plaque buildup here, and then you get thrombus formation. So what's the main difference between, so I'll try and answer as many as I can. What's the main difference between NSTEMI and unstable angina? So we're going to talk about that just on the next slide, actually. So let's go through that now. Here we go. Unstable angina, NSTEMI, STEMI. So like we said, unstable angina is partial occlusion, NSTEMI is partial occlusion, and complete occlusion results in a STEMI. Like Schwabe here just said, the plaque is permanent, which means it's important to try and eat as healthily and stay as healthy as you can for your entire life. In terms of the difference between these three, they all present the same. So they all present with kind of that constant crushing chest pain radiating to your left arm, left shoulder, you're feeling sweaty. Stable angina normally occurs on exertion, unstable angina occurs at rest. So that's the main differentiation between stable and unstable. But stable angina is not part of ACS. Then also what happens is angina, it's going to be ischemia. So when you get ischemia to your heart, that is what's causing your pain. Whereas infarction means actual cardiomyocyte death. So these cells are dying because they're not just ischemic, but they're actually infarcting. So they don't have enough oxygen or metabolic supply to actually survive any longer. How do you classify complete occlusion of the PDA? As could be complete occlusion, but there would be ST depression. I'm not sure I fully understand the question, but what the point is that you're going to have ST depression because it's a reciprocal change because of the electrical axis of the heart. So when you get occlusion of your posterior descending artery, which is normally from your right coronary artery, it causes ST depression, but the actual pathophysiological changes are going to be the same, if that makes sense. I'm not sure if that answered your question, but yeah, hopefully it did. And then the next thing we need to look at is our biomarkers. So in unstable angina, this is probably one of the most important features from here. It's going to be unstable angina causes normal biomarkers, and STEMI causes elevated because cells are actually dying. Is unstable angina a diagnosis of exclusion? So if a patient presents with central crushing chest pain, particularly with cardiovascular risk factors like high blood pressure, the key is going to be ruling out an MI. So in any patient that you suspect has a cardiac cause of their chest pain, you're going to end up doing these two investigations anyway. So if the ECG is non-specific, doesn't show ST changes, for example, and the biomarkers are normal, which we'll talk about next as well, then you can be relatively confident this is probably unstable angina rather than a STEMI or an NSTEMI. So biomarkers, we're going to talk about that next. What are our biomarkers that we look at in ACS? Troponin. Anything else? CK? CKMB. Okay, brilliant. So a few things, yeah. So troponin and CKMB, and then also myoglobin as well are the main ones to remember. And someone mentioned serial ECG. Serial is the most important word when it comes to investigations here. When I say serial, this means we're not just checking one ECG when the patient comes to the door, but we're checking repeat ECGs, ideally every 10 minutes. Because often the first ECG may be the same, but as the myocardial infarction changes over time, then you may start seeing some ST changes or T-wave inversion, for example. What is first line? That's a good question. So any patient that comes in with any condition, how I would recommend investigating is going to be a bedside approach, followed by bloods, followed by imaging, followed by interventional investigations. That's what we like to call the BBII approach. Bedside, bloods, imaging, investigation. Particularly in your clinical exams, if you can split it up into those four, it's plain sailing, they'll love you. So check your serial ECGs. What's CK? I'm just gonna have a chat about that. And then like those ECG changes that we mentioned before, those are the types of things that we would be expecting. Following this are blood tests. Following that approach, BBII approach, we're going to check serial troponin. This is the one that's most commonly done, particularly in the UK. And when cardiomyocytes die, then they release these markers of damage, such as troponin. Could you repeat BBII? Yes. So B is bedside, the first B. The second B is bloods. I for imaging, sorry. And then the second I is interventional imaging, which we're also going to talk about in a moment. Good, that's exactly right. So let's have a chat about these three biomarkers, because this also comes up really commonly as well. So the first biomarker to rise is myoglobin. Myoglobin normally rises within around 2 hours. If you guys are interested in what it is, it's kind of an oxygen carrying, yeah, there you go. What is myoglobin? So it's an oxygen carrying pigment of your muscle tissue. It's the first one to rise and the first one to drop. So I had that question in my finals, what's the first marker to rise? And it's myoglobin generally. Then we have CK, so creatine kinase MB, which is a specific isoform of creatine kinase. This is relatively specific to heart muscle. You're welcome. This is relatively specific to heart muscle, but can also, other isoforms are often raised in conditions such as rhabdomyolysis. This rises a little bit later, kind of 10 to 24 hours. And then finally, troponin is the one that rises normally around, say, 12 hours and can stay risen for around 10 to 12 days. So out of those three, what do we think is the most specific and sensitive test? Yes, absolutely. That's why we're all using TROP, is because it is the most specific and it is the most sensitive. Brilliant. Does all of that make sense? Just remember those three and remember those facts and you should be fine. How often do you take bloods to see the trend? So you're going to normally take it initially. So when the patient comes, you think this is ACS, take a TROP. Often this is then repeated at 3 hours and then 6 hours. Every hospital has different guidelines as when to check them and what the cutoffs are. But if you remember that, so initial 3 hours, 6 hours, and in some cases, often, they'll have them taken again at like 12 hours as well. But normally that would be the first marker to rise. I don't know how to stop people writing on here, but hopefully I'll figure it out. Good. Oh, that was going to be my next question. But yes, the coronary angiogram is your diagnostic investigation of choice. That comes up in your exams. That's going to be your gold standard imaging for a patient with suspected ACS. So if you want to know what a coronary angiogram is, I'm sure many of you probably do know. What it is that you get basically puncture an artery. How is it done? Good question. So you either go via the radial artery or the femoral artery in the groin, generally. As a thin catheter is passed up towards your coronary arteries. You're going to put a little bit of dye through that and then run some x-rays, and you can see exactly where the stenosis is. And then you can also put in, you normally balloon it up if there is something to balloon up, or you can even put a stent in as well. And you're absolutely right, it's done in the cath lab. Is it therapeutic? Yes, so the angiogram itself is the investigation, and then the therapeutic part is gonna be, anyone know what that's called? Yeah, so PCI, so angioplasty or stent insertion. So PCI is percutaneous coronary intervention, which is a management of ACS, which we'll talk about now. This is your first example of what we call a multi-step SBA. What that means is you get the initial case and you work through the whole case from diagnosis, management, investigations, etc. And it gives you a really good holistic view of how to manage a patient with a condition, in this case, ACS. So what do we think our initial management is going to be? You see this patient, you think it's ACS, and what are you going to do? A, B, C, D, or E? We're getting A's, we're getting D's, A, D, A, D. Okay, so let's have a look at the answer. A. Good. So on the whole, this is going to be our first line management. So morphine for pain relief, a couple of puffs of GTN. So this causes vasodilation of your coronary arteries, and then dual antiplatelets. MONA, exactly. And what is MONA? So I'm guessing you guys know. So morphine, oxygen, nitrates, and aspirin. It's a little bit incorrect in that you're not going to put every patient on oxygen. You're only going to give it if they're actually hypoxic with low saturations. And you're not just going to give aspirin, you're going to give both. So good. So remember that. That's the first thing you're going to do, dual antiplatelets with GTN and morphine. So we've given them that. We've given them some, just to check, do you give this after ECG and TROP before coronary angiogram? Yes. So you give this if you're suspecting a patient is having an MI before any further investigations. Generally, you can give that management. Why aspirin and clopidogrel? So they work by slightly different mechanisms, but they're both aspirin and clopidogrel are antiplatelets. You're trying to stop that thrombus from growing. So all the platelets are adhering to that thrombus, getting bigger and bigger and bigger, and it can cause rupture. So by giving 2 antiplatelets at high doses, you're preventing those platelets from aggregating. So we're getting lots of B's here. So in view of the ECG, 4 hours since symptom onset, which of the following is the best management? So most of you are saying B. B, okay. So yeah, the answer is PCI. Would it be PCI since, yes, that's absolutely right. So the reason that is PCI here, which we'll talk about on the next slide as well, is that the patient has presented within 12 hours of symptom onset. There are some other criteria which we'll talk about next. These other options are not appropriate. Fibrinolysis has worse outcomes compared to PCI. So if you can do PCI, that is ideal. And thrombectomy is not appropriate here. And this is fondaparinux, which is a type of low molecular weight heparin. That alone is not going to solve the problem. Let's have a chat about these questions, which you are asking here. So it should be on this slide, the answers to those. So oxygen only give if your saturation levels are low. Like we said, analgesia, GTN, with your dual antiplatelets to stop that thrombus from propagating. And then patients need to be anticoagulated. We're trying to stop further infarction from taking place. We're generally going to give low molecular weight heparin or unfractionated heparin. So anyone know the difference between these two, or when we might use one over the other? Assuming this patient has good renal function and is male, so not pregnant. Yes, if you need to do PCI later. Interesting. So yeah, that's short-acting, long-acting. Yeah, these are all correct, absolutely. So low molecular weight heparin is longer acting, whereas unfractionated heparin has a shorter half-life. Low molecular weight heparin is given subcutaneously, unfractionated is given IV, which means if you're planning to take this patient to the cath lab to do an angiogram or to do PCI, ideally we want to give unfractionated heparin. It has a shorter half-life, so it's more reversible, so there's less risk of bleeding. That's the main point in terms of this case at the moment. Management, if the symptom onset is less than 12 hours, like we talked about here, and PCI is available within 2 hours, then we want to anticoagulate them and take them to the cath lab for PCI. So that involves popping your catheter in, ballooning up that artery that the stenosis is in, and then popping a stent in. So technically, the guidelines are actually not just within 120 minutes, but if you want to get more technical about it, it's within 120 minutes of when thrombolysis could have been given. Fibrinolysis even. So if you can get access to fibrinolysis within half an hour, for example, but you can do PCI in 2.5 hours, that's still technically within that window, if that makes sense. But this is going to be your ideal investigations. Then if your symptom onset is less than 12 hours, but you can't get to PCI, then we can use fibrinolysis. What might we use? Any drugs we know of for fibrinolysis? Alteplase, yeah. Good, yeah, so things like streptokinase, alteplase, yeah, those are all examples of fibrinolysis. As I said, slightly worse outcomes, the PCI is preferred if at all possible. Good. Yes, you will get a copy of the slides. It will also be recorded as well. Sorry, could you please repeat in what instance would you use low molecular weight heparin and unfractionated heparin? So unfractionated heparin, particularly if you have impaired renal function, is better, but it's harder to monitor as well because you need to take regular blood tests. Also, if you're planning to take the patient to theatre or to the cath lab in this case, we're generally going to use unfractionated heparin because it has a shorter half-life, so therefore it's going to wear off quicker and the patient is less likely to bleed significantly during the procedure. Yes. Sorry, would you be able to go over the timing? So even if they have shown symptoms, so if they've shown symptoms for 7 hours, it's still within that 12-hour window, then you can consider PCI or fibrinolysis. If you're over 12 hours, then we manage medically with your anticoagulants, antiplatelets, etc. What is fibrinolysis? So fibrinolysis is giving a drug such as alteplase, streptokinase, which essentially breaks down clots. So when there's a big accumulation of fibrin degradation products, thrombus, then that can help break it down. It increases your risk of bleeding overall. So if you, for example, had an ischemic stroke within the last few months, then we're going to have to avoid it. So yeah, there are lots of contraindications to fibrinolysis as well, which is probably reasonable to look at as well for your exams. Good. I wish I could answer all your questions, but I feel like we'll be here for about 4 hours. But we'll get through as many as we can. We have a couple of members of our team on here as well, who will try and answer your questions as we go along. So your management. So unstable angina and end-STEMI. So moving away from this case specifically, we're thinking about patients who don't have ST elevation, but these are patients with unstable angina and STEMI. So dual antiplatelets once again, so aspirin and clopidogrel, 300 milligrams, and then we can use something called a glycoprotein 2B or 3A inhibitor as well. Host, could you please check your mic? It's crackly on my end. Yours sounds good. No crackles here. Okay, yeah, okay, good. I wish I could solve your problem, whoever said that, I'm sorry. So yeah, we go for unstable angina and STEMI exactly the same, high dose aspirin, high dose clopidogrel, and then we can, if the patient is intermediate or high risk, we add on this drug. What does this drug do? Anyone knows what this drug does? Yeah, so an example of one of these is going to be tirofiban, which is spelled like this. Tirofiban. How do I send that to everyone? Oh, everyone. There's an example. Good. So yeah, so these all have a similar end outcome, which is they're antiplatelets, but work via slightly different mechanisms. So if they're intermediate or high risk, which I will talk about next, then we add on this as well. Similarly, we're going to give fondaparinux rather than just low molecular weight heparin this time round, and then unfractionated IV heparin if you're planning to do an angiogram within 24 hours. So in terms of intermediate or high risk, so this is going to help you stratify the patients that you're going to, whether they need angiogram or PCI urgently or during this admission. So have you guys heard of the GRACE score before? It's recommended by NICE in the UK now that any patient with, sorry, why do you give tirofiban? So it's another type of antiplatelet. It acts via a different mechanism to aspirin and clopidogrel. So essentially, if you can target multiple mechanisms with the same outcome, then you're going to maximize your chance of reducing that thrombus from growing, essentially. Can I please explain? Yes, I'm going to assume you mean the GRACE score. So the GRACE score, once again, is now a common exam question because NICE have recently changed their guidelines. What it does is that it estimates your admission to 6-month mortality for patients with acute coronary syndrome. So you have a patient you think has acute coronary syndrome, you're going to calculate their GRACE score to estimate their 6-month mortality. What factors are in the GRACE score? Good question. So lots of different factors. So the main ones to try and remember are things like age, heart rate, your systolic blood pressure, creatinine, whether the patient has had a cardiac arrest on this admission, whether they have ST elevation, lots of different factors. You plug all of them into this algorithm, which you can find online, and then you come up with the patient's risk. So if they're low risk, so normally this means a 6-month mortality less than 3%, conservative management. So all of these bits that we've discussed up here. So dual antiplatelets, anticoagulation. If their risk is above 3%, so intermediate to high risk, we want to angiogram them during this admission within 72 hours. And then if they're clinically unstable, hemodynamically unstable, for example, we want to angiogram them immediately and then do PCI as well, which they probably will need. Do you give morphine in the management? If they're in pain, you can give morphine. Generally, patients will need morphine at initial assessment anyway. Fine, let's move on. Long-term management. What kind of things do you think, before I bring it up, that we're going to need as secondary prevention? Statins, ACE inhibitors, beta blocker, good. Perfect. So beta blocker. What's the most common beta blocker that we're going to use? A nice cardioselective one, bisoprolol, perfect. ACE inhibitor, example. Ramipril, great. Antiplatelets, so dual antiplatelets for a year, then aspirin indefinitely. So these patients should be on low dose aspirin, 75 milligrams, essentially for the rest of their life. And then high dose statin, for example, 80 mg of atorvastatin. So risk factor management. All of the things that someone's already actually mentioned here. So managing your diabetes, hypertension, smoking, diet. You're absolutely right. So cardiac rehabilitation for patients who have had an MI is quite helpful as well. You know, things like physiotherapy, exercise, guidance programs, all of these are still advised by NICE as well and can be quite helpful. Perfect. I hope all of that made sense. So back to our multi-step SBA, back with the same patient. You've managed, you diagnosed them, you've managed them, he's had PCI now, and he's been discharged with secondary prevention. 2 weeks later, he's got increasing breathlessness on exertion, chest pain lying flat, and has a fever. Lots of E's, E. Good. So I'm assuming that means everyone has heard of Dressler syndrome. What is Dressler syndrome? No, not heard of it. Okay. Yeah, absolutely. I'll explain it now. So Dressler syndrome, you're absolutely right. Is someone said that so it's an autoimmune reaction which occurs following a myocardial infarction. So often around 2 weeks following a myocardial infarction, what happens is when the heart muscle dies, it releases what are called neoantigens. When these are released because of that damage, you have the body reacting to them in an autoimmune fashion, which essentially results in pericarditis. So it's an autoimmune pericarditis, like people are saying here, perfect. And pericarditis presents with your pleuritic sounding chest pain, worse lying flat, relieved by lying forward, sitting forward even. Good, well done. You guys got that correct, fantastic. So complications. I like to split this up into complications which occur before 2 weeks after MI and after 2 weeks, because this often comes up in an exam where they try and separate into these two categories. Once again, take a picture if you want, otherwise the slides will go online anyway. These are the main things that occur before 2 weeks, and these are the main ones that occur after 2 weeks. So we have things like arrhythmias, VSDs, mitral regurg, pericarditis, and then after 2 weeks, heart failure, Dressler syndrome, for example. Now, this is a cool diagram. I just thought it was cool more than anything else. But yeah, so we have, pericarditis is going to affect your pericardium. Your ventricular septal defect affects the septum in the middle here, which separates the two ventricles. You then have ventricular wall rupture, which actually affects the wall of the ventricle over here. And yeah, I'm glad you guys think it's cool. I agree. And then what else was I going to say? Ventricular aneurysms obviously affects the ventricles. And then finally, papillary muscle rupture. You see on the left here, we have the mitral valve. These are your papillary muscles attaching to the ventricles. If you have an infarction, then obviously these become loose and floppy, and then you get mitral regurgitation. What does the heart muscle release during Dressler's? They're called neoantigens. Pericarditis versus Dressler's, good question. So yeah, and like Imogen has said, so Dressler's is autoimmune because of those neoantigens post-MI, whereas pericarditis, like in most cases, is normally viral. So for example, most commonly following Coxsackie virus. So that is not an autoimmune pericarditis, whereas Dressler's is an autoimmune pericarditis. How do you manage Dressler's? Normally just with NSAIDs, and patients will get better by themselves. So a summary, myocardial infarction. So we have, like we talked about, main underlying causes: atherosclerosis, coronary artery disease. You want to manage your risk factors like hypertension, smoking, diabetes. Those are your other key risk factors. What is the relevance? The relevance is just the fact that you know they exist, really. So you know that they exist, which means, and that they are the predominant cause of why Dressler's occur. So when the heart muscle is damaged, these neoantigens are released, your body responds in an autoimmune way, which inflames the pericardium essentially. And then that's why you get this autoimmune pericarditis. Like we said, it's important to remember how those ECG changes reflect the territories that are being affected, like we said. You know your acute management now, which is brilliant. All of that makes sense. Like my colleague here, Zach, has said, we're going to be, the rest of my team are taking notes of all of your questions, and we'll try and get back to you. I just don't want to be stuck here keep you guys here for hours and hours. Brilliant. I hope that was useful. That's a kind of a crash course. All of these are basically going to be crash courses. We want to be able to cover as much as we can. We have nothing better to do. Yeah, I think we're all in the same boat, to be honest. So next case. Case number 2, we have do you know roughly how long the session will run? So we have one more case, so maybe another half an hour, hopefully. So 55-year-old male presents back to the emergency department, different chap with severe chest pain and back pain, dizziness and nausea. He has never experienced anything like this before. Ooh, sounds dodgy still, and reports he is usually fit and well. Here he is with his chest pain radiating to his back. He takes amlodipine, which we know is a calcium channel blocker, probably for his hypertension. Lots of people saying aortic dissection, AD, aortic dissection. Anything else? Pericarditis, AAA, lots of pancreatitis. Oh, I like pancreatitis, yeah. That's an interesting one. So pancreatitis, obviously, we normally are learned, it's an epigastric pain, but epigastric pain, chest pain, patients often kind of do mix them up. So yeah, that's an interesting one, good. So we have observations. What do we think about these? Hypotensive, I'd agree, he's very hypotensive. Tachycardic, shock, exactly. Alarm bells ringing, yes, perfect. So yes, he's in probably some kind of shock. We'll have to figure out what it is. He is tachypnic, not great, absolutely not great at all, and his sats are low. So I would be mostly worried about this. That is bad. So imagine you're in the emergency department, taking a brief history, you get those obs. This patient is going to be my priority. A to E approach, perfect. Very bad, yes. So, like I said, unfortunately, this doesn't work. We'll fix this for next time. Aortic dissection, most of you guys are saying, these are some other things you may be considering. I probably don't have time to go through exactly why it's not all of these, but just remember particularly these three normally cause pleuritic chest pain. My initials, yeah. Pleuritic sounding chest pain. Pneumonia, you're going to have a productive cough. Pulmonary embolus, shortness of breath, pleuritic chest pain, normally with risk factors for pulmonary embolus, such as long haul flight, oral contraceptive pill, and pneumothorax. This patient doesn't really fit the classic demographic of a pneumothorax either. So yeah, my top differentials would probably be one of these two. So this patient is having an aortic dissection. It's bad news. Pneumonia, would it cause sudden chest pain? It's unlikely to be sudden. It's more likely to be gradual and pleuritic. So when patients cough and normally bring up their phlegm, they're going to say, ow, I got this sharp pain in my chest. What's a classic demographic for pneumothorax? Okay, that's a whole nother teaching session, but you can split them up into primary and secondary. Primary, like you're saying, normally young, thin, Asian, tall males. Secondary is patients with underlying lung disease like COPD or asthma. So this chap has an aortic dissection, which is pretty bad news. Bit of pathophysiology. So like you can see in this diagram here, it's a tear in the tunica intima. Blood is flowing up here, there's a tear here, bad news, and it bursts out into the tunica media. This forms a false lumen. This then propagates both proximally and distally. And then this distal flow particularly is going to occlude some of your branches of the aorta, which is very bad news. Most commonly due to hypertension, smoking, those are your biggest risk factors, but also a couple of connective tissue disorders as well. Good. Hope that all made sense. So these are our two main classifications for aortic dissection, which we need to know about. The one that we need to know in detail is going to be Stamford. This is the one that's used almost universally. Type A, type B. Do we know which one's worse? Type A or B? Type A, B, A. Okay, so mainly A, some Bs in there as well. So type A is a lot worse, which we will talk about in a moment. So type A's affect the ascending aorta. So like you can see here, the aorta comes up here, the dissection occurs somewhere along that region. Now, once again, common exam question is, how does this relate to the anatomy? Well, a type A dissection occurs proximal to the left subclavian artery. A type B dissection occurs distal to the left subclavian artery. Remember that, because that will almost inevitably come up in your exams. So type A affects here, it can affect the aortic arch, it can affect almost the aortic root and the aortic valve as well, whereas type B doesn't affect that ascending aorta. It normally affects the descending thoracic aorta, often sometimes all the way down to the abdominal as well. Could you repeat the subclavian artery? Yes. So type A affects the part of the aorta that is proximal to the left subclavian artery, whereas type B affects the portion of the aorta that is distal to the left subclavian artery. All of that makes sense, guys? Still with me? Yep. Fab. All right. Moving on. Investigations. Now, back to that BBII approach. Bedside. We're going to do an ECG. ECGs, we need to try and rule out a STEMI. Which one is worse? A is worse. We need to rule out a STEMI. We need to rule, often in an aortic dissection, you're going to see very non-specific changes. Patients may have ST depression or have a normal ECG as well. So don't expect any massive changes on there if you're suspecting a dissection. Bloods. So imagine you're in your clinical exams, they're saying, what are you going to do next? Well, the first thing I'm going to do is do a bedside test. The most important thing is going to be an ECG. I'm also going to do blood test, full blood count. Patients that present with bleeding obviously need a full blood count to see what their hemoglobin is doing. But also, just because their hemoglobin is reassuring, it doesn't rule out an acute bleed because it takes time for that hemoglobin to drop. Now, this is a tricky question. What is the most sensitive marker of the amount of bleeding in the patient who's having an acute bleed? It's like whether it's blood tests or findings or like what kind of things? Urea, lactate, reticulocytes, hematocrit. Ah, okay. I've seen a couple of good answers. Okay, so the guys who said things that aren't blood tests are right. So blood tests are not particularly sensitive at picking up bleeds. Like we said, things like your hemoglobin can take a while to drop if you're having an acute bleed. The most important thing is going to be your hemodynamic stability. If you learn your grades of shock, you'll know that blood pressure is very late to drop. So once again, just because the patient is normotensive doesn't mean that they're not having an acute bleed. This chap here was very hypotensive and is normally hypertensive, which means actually then that's even more worrying. So hemodynamic stability, urine output, these types of things, respiratory rate can increase, but once again, that's a little bit less specific, but it does increase early on as well. Renal function, we want to get the patient's renal function. They're going to need it prior to having a CT with contrast, which is kind of your gold standard investigation. And patients who bleed out a lot, who have lost a lot of blood, can have a pre-renal acute kidney injury secondary to hypovolemia. So the answer is BP. The answer is really going to be your clinical findings. So I think mainly I'd say heart rate. Urine output also drops pretty early on as well, but not all patients are going to have urine output measured in the emergency department. What is BP? Blood pressure. Is ultrasound gold standard or CT? CT is gold standard. Capillary refill time is good as well, but blood pressure occurs, like we said, can drop quite late. But don't rely on blood tests, essentially. Next blood test we're going to do, group and save and cross match. We will need to know the type of blood that the patient has. And these patients are going to inevitably need a transfusion if they're going to theatre. So cross-match 4 to 6 units so that that is available. As F1s particularly, that's going to be your job. If this patient's having aortic dissection and you forget to do that and no one remembers to check, and that patient could die. So remember to do that. Difference between group and save and cross-match. Group and save is you're checking the patient's blood type to ensure that the blood bank is aware of what type of blood the patient will need if it is needed. Cross-match is saying, okay, this patient needs X number of units of blood and gets it on standby, like you're saying, for when the patient needs it. Venous blood gas, you're going to check the hemoglobin, degree of acidosis, and lactate. So very quick test. You pop it in the machine and you should get some quick findings. So imaging, chest X-ray, CT angio. Chest X-ray is first line, CT angio is your gold standard. What do we see on the chest X-ray? What types of things do we see here? Major hemorrhage protocol, there are specific guidelines for that. It's going to depend on your trust. I don't think this patient quite fits that category. Widened mediastinum, Heller notch there, yes, agreed. So yeah, we have a widened mediastinum, so that's one. And then, which is, can occur in patients with aortic dissection. And then this very prominent aortic knuckle, which can also occur with the dissection. This patient also has a pretty large left-sided pleural effusion as well. So it's not actually that the lung is smaller, it's that there's blood there essentially, which can occur particularly in a type A dissection. So those are the types of things we're looking out for. But obviously a normal chest x-ray you can't rule out a dissection based on that. Whereas with CT, that's what we need to end up doing. So back with our chap, we think he's having a dissection. What was 2? What was 2? Oh, that's the enlarged aortic knuckle. What is your immediate management? So we have this chap, we think he's having a dissection. What are we going to do? I'm seeing lots of A's, I'm seeing lots of C's. A's, C's. Okay, so it looks like there's a split between A and C, and I would agree that those were probably going to be my top 2 options. In this case, this patient is hypotensive and tachycardic. Your priority is to see whether they're going to be fluid responsive. You give them a bolus of fluid, will their cardiac output increase? Will their tachycardia and hypotension improve? So C is the correct answer. However, I would also understand, particularly early on as junior doctors, potentially initiating a peri-arrest call. But once again, it takes time for those groups of people to arrive. All the people you need there is going to take time, by which time the patient could have deteriorated further. And the question to you from your seniors is going to be, what have you done to actually try and stabilize this patient? So we want to try and give fluid bolus to see whether they're fluid responsive. What are you looking for after you give the bolus? You're looking to see whether the heart rate drops and the blood pressure increases. So A is the same as a crash call, essentially. So fluid bolus, in this case, I would give 500 milliliters of Hartmann's, stat, or normal saline. 250 milliliters is not enough. It's basically like a can of Coke. So I would give that. And blood pressure can take time to respond, but that's the most important thing you can do in the acute phase to try and improve his observations at this point in time. Yes. Sorry, there's loads of questions there. I'll move on, but hopefully someone from our team can answer those. Good. I hope that makes sense. So that's why we're going to give a quick fluid bolus to see if he responds. So we've given him a fluid bolus. His obs haven't changed massively yet. You've got some blood test results back. What do we think of these blood test results? What's going on? Low HB, anemia. Good. So this is a borderline microcytic anemia, but it is kind of essentially normocytic at this point in time. What's your first line management then? A, blood B, call 999. I think you are 999 in this situation. So well, I'm seeing B's and I'm seeing A's mainly, I think. Yeah, so the answer is B, and I'll talk through with the CT as well. So you're right, the patient is going to need surgical repair. You're going to need to, that's going to be your definitive management in this case, but your priority is to make sure blood is available and to give the patient blood. Pumping this patient full of fluid is not really going to do anything. The rule here is that you replace like with like. If patient is losing blood, you want to replace their losses with blood. If they're vomiting profusely, fluid is fine, but blood you want to try and give transfusion. What's part of transfusing before repair? It's all part of perioperative stabilization, and it also increases the likelihood that they actually survive to theatre. A huge proportion of patients, around 50%, die before they even reach theatre. So we're trying to keep them alive, basically. Tranexamic acid as well. There are different schools of thought, but some guidance still, can say that tranexamic acid is a good option. Don't usually transfuse below 70 HB. So there are obviously specific cutoffs for HB. Often, they say below 80 with cardiovascular comorbidities or below 70 without. But in this case, you think this patient is having a surgical emergency, is hypotensive, in shock, bleeding out. Those values are almost meaningless at this point. So they're going to keep bleeding, and actually that value, by the time you get it back, is going to be even lower. So you need to give them blood. The CT shows what's called an intimal flap that you can see here, and this is, so an intimal flap is the thing you're looking for on CT. So try and remember that for your exams. Intimal flap. Good. Sorry I couldn't get through all of your questions there. So these have improved. Let's say the observations have improved a little bit. We're giving blood now. What's your further management? What are we going to do? A. Brilliant. So A is correct. A over B. And I'm going to explain on the next slide what I mean by blood pressure control. Obviously, monitoring means they're going to die, and an interval CT scan is inappropriate as well. They'll probably be dead by the time you repeat any CT scan. But let me explain what I mean by A there. Management. So like we said, type A is worse, needs surgery. Type B can be managed conservatively on the whole. The patients with type A will need a blood transfusion. They need to be perioperatively optimized the best as they can, and you need to try and keep them alive. That's your job as a junior doctor, or really any doctor looking after a patient with aortic dissection, to try and keep them alive until the surgeons can see the patient. Now, blood pressure control, this is what I mean by it. IV labetalol, have that stuck in your heads right now. IV labetalol for both of these. So obviously labetalol is a beta blocker. It's given intravenously. We need to make sure that this patient actually doesn't become hypertensive. The blood pressure rises too high, it can actually cause propagation of the dissection proximally and distally, which is going to worsen the situation. You want to pop a line in, and you want to monitor their blood pressure very closely. In this case, the patient is so hypertensive already, it's less appropriate, but the key point is you're monitoring the blood pressure, and if it gets too high, you can give small smidges of labetalol. You're welcome. So, and then obviously the definitive management is urgent surgical repair. For patients with type A, it's almost always done open. There's some clinicians that are trying to do it endovascularly as well, but on the whole, open surgery, you're replacing the aorta, often the root of the aorta as well. So that is how we're going to manage type A dissections. Type B can be managed conservatively. Why would a patient with AD become hypertensive? It's a good question. So in and of itself, the aortic dissection might not make them hypertensive, but when you're pumping a patient full of blood, if the rate, particularly if the rate is too high, or you're pumping full of fluid and blood, imagine your left ventricle is going to dilate, it's going to expand, and you're going to pump, your cardiac output hypothetically should increase, which means that the blood pressure also may increase as well. So that is more just a question of monitoring and seeing what your changes in terms of your management are doing in terms of the patient's parameters. Type B, I hope that answers your question. Type B can be managed conservatively, things like bed rest, analgesia, once again, labetalol. These patients should be at least in the high dependency unit. And then some patients further down the line may have a thoracic aortic, endovascular aortic repair, also known as a TEVAR. You don't need to know much about this, just know that this is the insertion of a stent. So as you can see in the diagram on the right of the screen, this is an example of a stent which is inserted for an abdominal aneurysm. So it's not the case, it's not the same procedure, but it's what the stent looks like. So this is passed up, normally via the femoral or radial arteries, passed up towards where the dissection is. You pop a stent in, and it reduces the likelihood of further dissection in the future. But this often doesn't need to be done acutely. Does that make sense? Yeah. Good, perfect. So what's the difference between TEVAR and EVAR? So EVAR just stands for endovascular aortic repair. The T just means thoracic, so thoracic endovascular aortic repair. Good. So complications. So the main two complications to be aware of are going to be tamponade, which in and of itself is obviously life-threatening, So when an ascending dissection ruptures, it can actually go into that pericardial space. The heart is more difficult for the heart to relax, and therefore you can lose output. So that's actually a very important complication to keep an eye out for. And then aortic regurgitation as well. If the dissection extends proximally, that can cause the aortic valves to become incompetent. Now, this is potentially one of the biggest take-home slides. All of this has been useful, hopefully, but remember this when you're seeing any patient with a suspected dissection. 20% die before even reaching the hospital, almost a quarter. A further 30% die before reaching theatre. So 1 in 2 patients are going to die before they even get to surgery. So if you're sitting in the emergency department, seeing a patient with a suspected aortic dissection, you need to keep them alive. That's what I keep saying anyway. Because what actually happens is if you can keep them alive to the time they get to theatre, there's a pretty good 5-year survival, around 80% for both types of dissection. So you want to cross-match, you want to give them fluid, you want to try and optimize them and get them to theatre as soon as you can. Good. Is aortic dissection worse than AAA? It depends what you mean by worse. A ruptured AAA has a pretty horrific mortality rate as well. I'm not sure of the exact numbers themselves, but I reckon they're probably pretty comparable. But they're both obviously surgical emergencies, and a vast number of patients die before they even get to hospital. No problem. So back to our chap. So we have helped him out a lot. He survived, congratulations. That's not specifically to do with this patient, but generally we need to think patients with Marfan syndrome, connective tissue disorder, are at increased risk of dissection. What protein are we worried about? E, 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 D, D, E, E, D. So D's and E's. So the answer is E. Well done, everyone. So E or D. So that's what people are saying, but the answer is E. So we can talk about all of these proteins if you really want, if that's helpful. Marfan syndrome, what other conditions are associated with it other than aortic dissection? Sorry, could you tell us quickly the signs of cardiac tamponade? So other than muffled heart sound, so raised JVP and hypotension. Aortic regurgitation, mitral valve prolapse, retinal detachment, big fingers, yeah. Yes, so most of those things, exactly. So these patients are normally tall. They can have displaced lens, so it can affect the eyes. Mitral valve prolapse, as you said, high arched palate. You know, they have long fingers, those kinds of things. They're at increased risk of pneumothorax. So a bunch of different potential comorbidities. And what is the inheritance pattern of Marfan syndrome? AD, good. So autosomal dominant. Perfect. So why don't we have a look at these? So what about elastin? What might that be defective in? Yeah, I mean, you could write that in the A&E clerking. I think that's reasonable. Or, you know, even difficult to hear, anything along those lines. Yeah. So elastin, cutis laxa, Ehlers-Danlos as well, can be affected. Yeah, so the elastin protein can be affected in both of those. TGF-beta, any ideas? Nope. So TGF-beta associated with lots of cancers, also associated with heart disease, and there's actually some association with Marfan's as well, but less so than E here. P53 is cancer, and collagen, for example, is osteogenesis imperfecta would be an example of that. Okay. But often lots of different conditions can be affected by lots of these. Brilliant. Hope that was useful. So our final summary of the day: aortic dissection, chest pain with back pain, and hemodynamic instability. We need to rule out the dissection. That's your absolute priority. We need to keep them alive to theatre. It occurs when there's a tear in the tunica intima, the blood splits the vessel wall and it dissects into the media. Type A is worse than type B. Type A, they'll need urgent surgery. Type B can often be managed conservatively. And now we know a little bit about the anatomy as well. So distal to the origin of the left subclavian is B, whereas proximal is type A. The gold standard investigation is CT angiogram with contrast, which will demonstrate your intimal flap. And then, like we said, type A, blood pressure control and surgery, and type B usually only requires blood pressure control. Good. Does all of that make sense? Why does type B not bleed out? That's a good question. So I guess, yeah, so that's exactly what I was going to say. So when you think about, if you think about it, the heart is a muscle. The more proximal you are to where the pressure is being produced by that muscle, the higher the pressures are going to be from the aorta. The type A's, they're going to bleed out a lot more. Patients become more hemodynamically unstable. Type B is more distal, so less likely to bleed out. So any other questions, pop them in here. We'll try and get back to you. Some further information for you guys. So a bit about us very quickly. So BiteMedicine, we want to help you guys pass all your exams. Being self-isolated sucks. So let's help you out the best that we can. We need your feedback. So if you guys could please, use that QR code, that would be brilliant. Or you can use the link here. So your feedback is incredibly useful. Thank you. I hope you found it useful. We're going to do these a lot more regularly. We want to know what topics you want to cover, how often you want these to be done. We have this textbook over here you can see on the right for sale. One of the best textbooks on the market, I must say myself. And our new website coming soon as well, which hopefully is going to change medical education and how you guys study. So if you could use that link, I'll paste it again because you guys are being so nice with all your compliments. Thank you. Thank you. We'll be back. If you want to, follow us on our socials, pop us an email if you want to help out, and please fill out our form. I love you all. Amazing doctor, thank you. You guys are amazing. Where you find the link to the following session. So everyone here has signed up. We have your email addresses. We're going to email all of you. The next one in the next couple of days, hopefully, depending on what you guys say on this poll. And yes, you too, all of you guys stay well, and we will hopefully see you soon.
If you have any further questions, then feel free to message us on Facebook or to ask Azim now if you want. Can you guys hear me? Oh, damn. Oh.
Okay. Okay, let's still, okay, yes. Perfect. Okay, so yes, pop more questions on here. Pop us an email. You've got our email address there. And stay in touch. You can buy our textbook, and we will let you know as soon as we know the next date, probably in the next couple of days for the webinar. Okay, take care, everyone. We're going to shut down the meeting.
Oh, wait. Azim, they've got a couple of questions.
Oh, questions, please. Okay, sorry, yes. How can we download the slides? We will upload the slides, and you guys will have access. We can also pop it in the email as well. How do I get the textbook? Yes, sorry, go to our website, www.bitemedicine.com. Here it is. Go to our website there, www.bitemedicine.com. Can I get friends to join this? If you could just ask them to please sign up. Our links, the sign up links are all over the internet, mainly on our Facebook page and Instagram pages. We will be making more room. There are almost 1,500 people signed up for this, but we will try our best. So please ask them to sign up. What med school did I go to? I went to King's for my MBBS, and I went to Imperial for my BSc in surgery. Will we be emailed the feedback form? I mean, we can, but it's also there. We just didn't want to spam you guys. Would you? Yes, absolutely. What else? What's the best way to contact you for information packs for teaching? Pop us an email here, admin@bitemedicine.com, and we will send you the information pack.
Yeah, we're going to have a website soon, a new updated website, where we hope we're going to have these webinars, and the resources are all going to be up there, the recordings, the PDFs. So it's going to be a neat little collection for you guys to study from. Yeah.
Cool. Any other dying questions before we close the meeting?
I'm currently, we have a couple of textbooks remaining. They are for the OSCEs. We don't have many left, but yeah, it is for delivery.
It'll be delivery. We won't put coronavirus on it, I promise. And they're really, really good.
Yes, so for theory, we're going to have an online textbook that's going to go alongside the launch of our new updated website. It's very comprehensive, but at the same time, concise enough for you guys to just retrieve the high yield information to excel in the exams. What would be the launch of the website?
I think that maybe about the textbook. The textbook should be delivered within kind of 3 to 5 business days,
Yeah.
depending on whether Royal Mail is working properly. The theory book, so we don't have a separate theory book. This textbook has a lot of theory in it with loads of cases like the ones we've done already. So that you probably will find it useful anyway. And we're going to be working hopefully on some SJT stuff in the future. We're a pretty young company, but we're trying to get as much out as we can. Website launch date, hopefully within the next 2 weeks. Everyone, we have all of your emails, so as soon as it's launched, you guys are going to get the emails, and hopefully you guys will find it useful. When will the online textbook be ready? Within the next 2 weeks. Probably the best online textbook on the internet at the moment, in our opinion. I love your OSCE book. We love you guys. Is the website going to be free, or do we need to buy a subscription? There will be a lot of cases for free, but to get full access, we're still trying to figure out the exact logistics. Have a great weekend and stay safe.